and welcome back to lecture. So this is ALH 7 and we are on chapter 33 part 2 for this week. So this is where we left off on part 3. So I kind of wanted to review this, and we talked about it in class, so it'll just kind of jog your memory again. But we're talking about sterile technique, and sterile surfaces must never come in contact with non-sterile surfaces. So we say sterile to sterile, and this is so important. We've talked about why honesty is important, how that's ethical, and I know that all of you understand and will apply that. If a break occurs from the sterile to sterile, then obviously we need to stop everything and start over. What memory aids might help you understand the importance of sterility in the surgical room? Well, so far, the things we've worked with in the classroom, everything sterile has been white, and everything that is non-sterile has been like black or other colors that we work with. Sometimes sterile will be blue as well, like our sterile towels that we have worked with, those are blue, but our sterile drapes are white. Our gloves are kind of that cream white, and you just want to make sure that you don't break a sterile field. Medical sepsis directly affects the health and well-being of the patient, the physician, and all of the office staff, right? So we must practice this without failing. We must always use our medical asepsis and our surgical asepsis, depending on if we are doing sterile field or not. So here's a good visual, and you can see here that the sterile field above the waist. See how his hands are above the waist? Now, tell me what I would say about where his hands are positioned. Yes, I would say out and away from body. Now, if I said out and away from body and he's standing this close to the sterile field, what would the other problem be? Correct, he'd be reaching over the sterile field. So very important that we don't contaminate, that he doesn't touch himself. It is taped off, so he's considering that sterile because he has a sterile gown on, but we want to be up and away from body. And then you can see again here that 1-inch border that we consider to be not sterile. Everything on the tray is also sterile. So what are the two greatest sources of contamination in a sterile field, do you think? Think about that for a second. If you thought hands and hair, you are correct. So learn what to touch and always keep hair secured and back so that it's not touching your shoulders. That's why we have our hair tied back at all times in the office, and that is our Sierra College protocol as well. You want to look at procedures 33.5, which describes how to open a sterile pack and create that sterile field. 33.6, which describes how to transfer sterile items to a gloved team member. 33.7, which describes how to pour a sterile solution into or onto the sterile field. And 33.8, which outlines the procedures for putting on sterile gloves without contaminating them. And you guys have been doing an amazing job. In fact, kudos to anybody who has just gone for it and been practicing and asked for that early checkup. Super proud of you. You want to make sure that you look at this in your book, the rules for maintaining sterile field. We will be discussing this. It is something that you need to know, do, understand, and apply. And again, you can find a better visual of this in your book. Let's talk about assisting with the surgery and assisting the physician. So we're responsible for ensuring that everything the assistant and physician will use in caring for the surgical patient is accounted for, it's ready for use, and it's prepared in a sterile manner. We want to establish a routine sequence and follow it each time, and this is what we've talked about. Your physician will have a certain way that he or she likes to do things, and you want to make sure that you are very detailed about that you learn that quickly and you follow that. It makes everything more smooth sailing, basically. You want to sort and place instruments and place scalpels and sharp objects conspicuously. Now, when it says that on the side, I want to make sure that you don't hide them, because then when the doctor is going to reach for something, they can be injured with that as well. So we talked about how we can hand blades or sharp scissors to the physician and how we should handle those. Once the site has been draped, the Mayo stand with the sterile field is positioned below the site, and the medical assistant stands opposite the physician over the patient, ready to help as needed. And again, the Mayo stand being positioned below the site depends on how we're prepping the patient, how the patient's positioned, what site we're using. A lot of times we will also keep the Mayo stand at the physician's waist level at all times. Again, when passing instruments, we need to work as a team member over time. The physician may not need to give any signals because the assistant, you, will be able to anticipate the instruments needed next during that procedure. And that's really the symphony that goes on as you get to know your doctor and you work with them. And that's how you get them to request you for surgeries once they notice that you really know what's going on and that you're anticipating what's coming next and what they need and how they like it, as well as setting up that tray exactly how the specific physician prefers. As your team works together, again, we want to continue to keep that sterile field while you're doing the assisting. So it's important that everybody is acknowledging the sterile field. And again, if that sterile field is broken, we need to stop everything and we need to create a new sterile field. When you pass, it's really important that you pass the instruments with a firm, purposeful motion so that the physician does not have to look up. Now, again, we talked about how careful we need to be as far as which way things are pointing and how we're holding it. So here you can see in these figures different examples, again, having that firm hold and passing with a purpose here. So we have, what is that here? Correct, that's a scalpel. What are these? Good, that's forceps. And how about right here? Those are scissors. And this one's a little bit harder to see, but if you look closely right in here, what do you think that is? And they're kind of here, you can look at what happens. That is a clamp, good. So see how they're holding it, again, protecting that blade and handing this to the physician in a manner that the physician is not going to cut himself. Same with the scissors here, holding in this manner. Okay, and this will also depend on the physician. In both my instances, all my physicians liked us to hold here and pass, and then they could put their fingers right into those handles. If a specimen is collected during a procedure, place that specimen in the appropriate container. It should be labeled, of course, and then we want to send that to the laboratory for analysis, and this will be whatever protocol is in your office. So when we're completing the surgical procedure, as the procedure ends, the physician begins to do the wound closure. So place the needle and needle holder and pass it handle first. So a lot of times you get to what we call thread that needle, right? We get to take the needle and put it into the needle holder facing the correct manner, which then you pull the suture out with the needle and the needle holder and pass that to your physician. You may also assist by cutting the suture and sponging the site. What steps occur after the skin closure? So the wound site is cleansed with wet and using sterile normal saline solution. And then we use sterile dry sponges by the surgeon or the assistant, depending on what your physician prefers. And next, a sterile dressing is placed over the incision and bandaging is applied to support dressing. So we want to look at 3310 eventually, which describes how to assist with suturing. This is something that we will just talk briefly about and need to know how we put the needle onto the needle holder and how we hand the sutures to the physician. And procedure 3311 describes how to apply or change sterile dressing, and we will be doing this in a couple of weeks as well, coming up I think next week maybe even. So post-op, So we've talked about the pre-op, we've talked about the operation, and now we're looking at post-op. And we really break things down in this manner. And so when we're studying this and talking about this and reviewing this, we want to know what we need to do pre-op, what we need to do during the surgery, and what we do post-op. So after caring for the patient, clear the sterile field, follow standard precautions. You need to be wearing disposable gloves until all contaminated materials are removed. Place the disposable equipment in biohazard containers and the sharps into the sharps containers, and check the room for any blood spills or bodily fluid or any other contamination. And we need to make sure that we disinfect that whole room, right? Then when we're done doing that, we can remove our gloves the correct manner so we don't contaminate ourselves, and we sanitize our hands. So you can use the clean gloves to disinfect the room, including the table, Mayo stand, side and back tables, and any other equipment in the room and the floor. So you can take those sterile gloves off when you're done with that procedure, because now it's post-op and you're cleaning up, and you can put a set of clean gloves on, and they don't have to be sterile in that case when you're disinfecting. Also, give the patient time to rest and recover from any sedative. You don't want to just jump them out of their chair and get them going. You check with the physician if there's any pain medications required, and sometimes that would be something that you might administer on site and then give them directions for their additional medication. You review any post-operative instructions with that patient, and you want to follow this, schedule the follow-up visit. And when you review post-operative instructions, it's really important to make sure that the patient is coherent and understanding, and also if there is a family member there, that you include them in this conversation so that they can help with care. And it's important to give all those directions in writing. We've all been there, right? We think we heard everything that the medical assistant or the doctor said, and the minute you walk out the door, you're like, what'd they say? How often do I clean it? Can I take a bath? So it's really important that all those instructions are in writing so that when they leave, they're able to go back and review. So that would answer, I was going to ask you why it's important to give the written instructions, but I kind of already gave you that answer. So important to know and important for your patient to understand warning signs. So you explain to the patient to call the office if any questions arise or if changes occur in any of the condition. So follow up with a patient within 24 hours of surgery with a call, and that might be a protocol with somebody in your office. That might be you because you work with a specific physician, or it might be somebody else that does all the follow-up calls. That will depend on where you are. And you never let that patient leave without the physician giving the approval and saying that that patient is ready to go. Wounds should be kept clean and dry, and this is very important to prevent infection. So it's important that we give them proper instructions for wound care when they get home. And you want to make sure that you tell the patient to call immediately if he or she notes redness around the operative site, bleeding from the wound, and sometimes there's a little bit of bleeding, so you explain to them that it means that there's, a blood flow of bleeding coming from that wound, fever, swelling, or an increasing or severe pain. Follow-up is important. When we do our follow-up, we use standard precautions to redress the wounds, and a lot of times they've been doing the redressing at home as well, but they come in for a follow-up and we need to have the doctor come in and check how the healing's going, and then we redress. So we use our standard precautions. That is not a sterile process, so we can use our regular glove. If the wound appears infected, you make sure that that physician examines it and gives the next step for that patient. No bandaging materials should be reused. I think we know why. And we want to keep the tape to a minimum, if possible. It just depends on if the physician wants everything closed off completely, or if we can tape the sides and have some air that comes in. And we'll talk about the different ways to bandage a wound. And if the wound is healed, you may be asked to remove the sutures, which we're going to be learning. It's a lot of fun. But again, that doctor has to make sure what your protocol is as far as if the wound is ready or not. And you'll have a protocol on how to determine that and what the system is for both staple and suture removal. So I have a question for you. How should tape